Hello students, welcome to Distinction Learning Platform, and on this platform you find revisions, questions, explanation to difficult topics, a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated with our upcoming videos. To make the story short, let us begin. Okay? So in this video, we're talking about examination revisions under what? OBS and Gyn. Okay? Question 1, question 2, we'll talk about it will be under OBS, and question 3, 4, it will be under gynecology. Okay, and the reason why we're talking about this revision question, we need to know on how to approach questions that can come under what? Under OBS and Gyn. Okay, even if this question maybe might not come, I'm not saying this is a question that's going to come, but the reason why we're talking about this is to show you on how to approach a case and on how you can write the correct diagnosis, and on how you can write the correct diagnosis, because you might know the correct diagnosis, but you find out to say you are going to be having low marks. So what are those things that you need to be following when it comes to writing? Okay, I'll show you about that. Anyway, man, I start talking about a lot. Let us begin from question 1. So question 1 is telling us a prime gravida at 34 weeks presents to labor ward with severe abdominal pain, vaginal bleeding, and the fetal heart rate is not picked up by Doppler ultrasound. Her BP is 90/50 with a pulse of 1.8 and a tense abdomen. Then they ask you, what is your working diagnosis? Okay, so what we'll be doing is like this. So I need to help you on how to come up with a diagnosis. Okay, so we've got this scenario, but the most important scenario is what? The most important thing is what? Vaginal bleeding. So you come here because this is vaginal bleeding, this one. So vaginal what? We say vaginal what? Bleeding. This vaginal bleeding, now you ask yourself to say, what are the conditions in a pregnant woman that can cause what? Vaginal bleeding. So there are a lot of conditions that can cause vaginal bleeding. So that's why we're going to write them. So that's why you start from. Don't just say you master something then you stay the answer. The reason why, if you say let's say you find out the incorrect answer here, basically everything that you're going to write here will be wrong. So on the working diagnosis, make sure that you are sure that that is your working diagnosis. It's what we're going to be doing here. So we'll start from there. The group, so that now we start nailing down to the to something that we are really sure that okay, this is the working diagnosis. So let's start with the vaginal bleeding. What are the cases that can cause vaginal bleeding in a pregnant woman? Okay, there are a lot of cases. Let's start with something that is more common. Let's start with what? APH. We know that APH can cause what? The vaginal bleeding. What else apart from APH? We know that okay, PPH can also cause what? The vaginal bleeding. Okay. What else apart from that? There's also what we call ectopic pregnancy. There's also what we call gestational trophoblastic disease. What else? Okay. And the other one is abortion. Okay. That one is abortion. As you can see, there are a lot of cases that can cause vaginal bleeding. Although there are others apart from that, but these are common cases. Okay, common cases that you can encounter. Now the question is, which one is it? Okay, that's the question that you can ask. Which one is it? So which one is that question that you ask yourself? Which one is it among these? Okay, and make sure that you study all these cases. These are the common cases that you need to understand. If you don't watch, maybe there's a video for abortion, there's a video for PPH. So there will be a video in the future for gestational trophoblastic diseases and as well as the ectopic pregnancy. Don't worry about that. Okay. So now, which one is it? So you come here to other clinical features that you've been given. What other clinical features? You come here, okay? You come to gestation age. So this one is also an important aspect. Gestation age, which is 34 weeks. Let's start now talking about the ectopic, gestational trophoblastic diseases and abortion, okay? So ectopic pregnancy, basically you lose the product of conception before the age of viability. The age of viability is 28 weeks in most of the countries, including Zambia. But according to WHO, we know that the gestation age will be 24 weeks, okay, then it's at least lower than what the gestation age that is considered to other countries like Zambia, okay. Now if you lose those that fetus before the age of viability, then we are going to consider that as what a abortion, okay. Sometimes these three, ectopic pregnancy, gestation to plastic disease, and abortion, they are considered as under what, early bleeding in what, pregnancy. So basically they are going to happen earlier than what, maybe before the age of what, viability. So what we're saying here is that all these cases, they most of the time they happen in what, less than the age of what, viability, basically less than what, 28 weeks. So let's just say less than what, 28 weeks. So these cases that we are going to cancel them because of what, this 34 weeks gestation age. If it was less than 28, now we can go to these differentials. But since we've cancelled that, now we go to something else. We've left with what, APH and the PPH, okay? So APH and PPH, what do you think? So PPH, postpartum hemorrhage, basically is the hemorrhage that's going to happen, or the vaginal bleeding that's going to happen after what? Like delivery, either C-section, okay, or maybe after vaginal delivery. Remember that the blood loss has to be what? Greater than what? 500 what? 500 mils when it comes to what, vaginal delivery, and it has to be greater than what, 1000 mils per what after what, C-section. That is our under PPH. We'll talk about, we have a video for that, you need to watch it, okay. So now this one also, they were saying after delivery. So, and this one is during what, during the intrapartum period. So this is 34 weeks. Yeah, they are not delivered, so they haven't delivered yet. Basically PPH is not the case here as well. So we cancel PPH. Now we've left with what, APH. APH, that is what, the diagnosis. So now we can't say here at APH, you can't say something like that, because APH is not a diagnosis, it is a syndrome, okay. It's something, it's a presenting thing that someone can come in. So it's not a diagnosis. A diagnosis is something that is causing vaginal bleeding. So now that's why we can go deeper when we start talking about what, APH. So let's go deeper under APH, okay. So you say here, okay, since this is a syndrome, and I can't put it here because that's not a diagnosis, it's a syndrome. So what are you supposed to do now? You talk about the causes of what, APH. Remember that under APH there are what we call placental causes. There are what we call placental what, causes. So placental causes, we know that there is what? The first one, abruptio placenta, the same one that I've talked about, abruptio placenta. There is what we call placenta what, previa. Okay, what else apart from that? We have vasa previa. Then the last one is what? Uterine rupture. Okay. Then apart from placental causes, we know that, okay, there are also other causes which we call local causes. Local causes, we can have sinusitis. We have cervical erosion, okay, erosion. We have cervical polyps, cervical cancer. Those are under what? Local causes of what? APH, okay. Now, since we have now the diagnosis or the differentials for APH, so we'll pick one as one of the cause of this scenario, okay. Even if they change the scenario, but as long as they are saying vaginal bleeding that is happening after maybe the age of after 28 weeks, basically that is APH. Now, if you talk about that, now go to the differentials. Which one is it? Now, what are you going to use so that you can pick one? Okay, don't just master. You come here again. Okay, we've used this one. Okay, we've used this one to at least narrow down up to that point. Then you go to where this one. This is another clinical. So all the clinical features that they are going to give you, you need to use them. You think about them. Don't just go direct to the answer like that. Don't master. So severe abdominal pain. Okay, severe abdominal pain. Then you ask yourself which differential is what relating to what severe abdominal pain. Which one is it relating to like severe abdominal pain? Which one is it? If you talk about the abruptio placenta, yes, abruptio placenta, it has what? Abdominal pain. There is pain there. What about the placenta previa? No, there is no pain. It is the bleeding that is there is what? Painless. And what is the color of the bleeding? That is what? Bright red. You need to know that, okay? So this is painless. What about vasopressia? Vasopressia is also what? 10 years. So if we start talking about the placenta previa and vasa previa, we'll talk about what the major differences that you need to take note of this. Okay, we talked about, so we need to watch APH. I talked about the difference between vasa previa and placenta previa, things that you can use to differentiate these two. Okay, in case the question comes in. Then the other thing is uterine rupture. Uterine rupture, there will be severe abdominal pain. So we've got two cases that can have abdominal pain. Okay, let's see now the true one. Okay, between abruptio placenta and uterine rupture. We come to another thing. Okay, we come here and fetal heart rate. So they are saying fetal heart rate is not picked by Doppler ultrasound. So the fetal heart rate is not picked. Both the uterine rupture and abruptio placenta, they are going to have decrease in fetal heart rate or absence of fetal heart rate. So this feature is also can be found in the abruptio placenta and the uterine rupture. This one, this feature, it is also important in all the cases. Okay, you go to another one. RBP is 90/50. Okay, that is hypotension. So 90/50, that's also in uterine rupture there is hypotension, and also in abruptio placenta there is hypotension. We move again. So there is also a key feature that's going to differentiate the two. So that's why scenarios are really important. They will make you to understand maybe a certain case. Okay, there's this one. This is getting interesting. So pulse rate also, as you can see, there's increased pulse rate. Okay, there's increased pulse rate both in abruptio placenta and uterine rupture. There is increase in pulse rate. But the most important thing is this one. This one. Let me just do this. Okay, that one. The tense abdomen. Tense abdomen. So what does that mean? What does that mean? So tense abdomen. Let us write it here. Tense abdomen. What does it mean? Abdomen. Okay. Tense abdomen. Let us write that out. Okay. Tense abdomen. What does it mean? So tense abdomen, when it comes to obs and gyn, it means that the tense abdomen, it means that the uterus is contracting like that. It is contracting severely. Okay, causing pain that a pregnant woman is going to experience. So tense abdomen, basically it is because of the uterus is contracting. Now the question that you can ask is, which one has the tense abdomen between abruptio placenta and uterine rupture? Which one is abruptio placenta? This one. Abruptio placenta is this one. This one, uterine rupture, doesn't have a tense abdomen. Why? Why doesn't it have tense abdomen? Okay, well, I'm not talking about the abdominal tenderness. I'm talking about the tense abdomen. Why doesn't it have? It is because the uterine rupture, the uterus has ruptured either completely or maybe partially like that. It has ruptured. If it has ruptured, basically all those contractions that were happening, the myometrium, there is injury to myometrium there. If there is injury to those myocytes there or myometrium, basically there will be decrease in the contraction because the myometrium is dead. Then there will be no contraction. So what I'm simply saying is that in the uterine rupture, the contraction are going to decrease to be decreased. Basically there will be absence of contraction. So the only thing now that we have here, according to the scenario, there is one feature that we see negative there. Okay, one feature that is negative for uterine rupture. Then you go to abruptio placenta. Okay. Now here, what are we going to say? Since we know now this is abruptio placenta, we are going to say the syndrome that they have is what? We say APH. Don't just say APH. APH what? Secondary to what? Abruptio placenta. But let's try to specify. This is severe abruptio placenta. Severe abruptio placenta. Don't worry. I'll talk about the grades of abruptio placenta or placental abruption. The reason why I'll talk about technical classification on the management. Don't worry. Okay. So we are saying secondary to severe. So we'll talk about the things that are telling us that this is severe severe abruptio placenta. So let's just say AP abruptio placenta. Severe abruptio placenta in what? So you continue in what? In a pravida at what? 34 weeks. So that's how you can complete the diagnosis. Okay, this is how they like if you say the statement in full like that. They like it. Okay, you're going to get full marks. Okay, now we proceed. Since we've understood the situation, now we proceed to this one. List 4 complications that may arise from this condition. So list 4 complications that may arise from this patient or from this condition. Basically, and if you talk about, and again, if you talk about what complication, if you talk about relating to obs and gyn, what are you going to do? Always you would separate maternal and what fetal complication when it comes to obstetric. Okay, maternal and what fetal. Always you need to be putting that in mind. So maternal and what fetal. Don't just write even if they say this 4. Okay, make sure that you will say this maternal complication. Maternal complication like what? We talked about the first one. So the first one is what? The maternal complication. The first one is what? So let's just use this one. Maternal complication. What is the first one? The first one is what? PPH. That is the first one. PPH. Okay, PPH basically, why am I saying PPH? Because that bleeding during what intrapartum there, it can progress to what postpartum period. Like they are bleeding during pregnancy, then also after delivery they can bleed like that. If they bleed after pregnancy because they had APH, basically that is what the complication of APH. So APH can have what PPH as one of the complications. Okay, they can bleed after delivery. Okay. Then we move on to another one. What else? What else apart from this PPH? They can have shock. Basically, they can have what? Hemorrhagic what? Shock, because they are what? Bleeding. They can have shock. They can also have hypovolemic shock. Okay, they can have hemorrhagic shock. They can have hypovolemic shock. Now let's just call it what? Shock. What else? They can have AKI. They can have AKI, acute kidney injury. Okay. The kidney can have problem because they having what? Low blood pressure there. They're having low tissue perfusion to the kidneys, leading what? To acute kidney what? Injury. Okay. What else apart from that? There's also, they can have also CHF. So congestive heart failure, they can have that. Okay. They can have CHF. Okay, congestive heart failure. Then they can have liver failure as well, or acute liver failure like that. Okay, they can have a lot of problems. Basically, I'm talking about the multi-organ failure because of what? Major severe shock. If they have severe shock, it can lead to multi-organ failure. Okay. Also, there is also another important thing, Sheehan syndrome. I don't know if you've come across that word, Sheehan syndrome. Sheehan syndrome can also come because if they have as one of the complications PPH can lead to what? Sheehan syndrome. What is Sheehan syndrome? Sheehan syndrome is because of this ischemic attack to the what? Anterior pituitary, whereby the maternal is failing to what? Produce hormones like luteinizing hormone, prolactin, those follicle stimulating, they are failing to what? Produce those hormones. That is the Sheehan syndrome. Okay. The other one. Let's talk about the fetal anomalies, okay? Or fetal complication. What is the first fetal complication? Basically, fetal complication, the first one is what? We know that fetal, let's say, intrauterine fetal demise. Okay, the fetus can die. Like in this case, as you can see, we are saying fetal heart rate is not picked by Doppler sound, indicating that the fetal is what? Dead. Basically leading to this condition, intrauterine fetal demise. Okay. Okay, I forgot the most important one here. Sorry guys. So we forgot a very important one, DIC, because intrauterine fetal demise can lead to what? DIC in the maternal circulation, disseminated intravascular coagulopathy. Don't forget about that. Okay. Then we go to another one. Okay. There's this one. There is if the fetus is not dead, basically maybe it can lead to what? Intrauterine growth restriction. Apart from that, then the other one is what? The other one is what? Intrauterine anomalies, fetal anomalies. So let's just say fetal anomalies, fetal developmental anomalies. They are going to have increased risk of that. So they are going to have fetal anomalies as one of the complications. Okay. So those are the complications that you can see. Okay. Now we proceed. Yeah, we go to the now major important part. Okay, even if even if we are like taking longer to what to explain concept, but make sure that this concept, even if we are talking about just one case in this like longer minutes, it's going, trust me, it's going to help you to understand also other questions, how you can what like manage other cases, or on how you can solve other cases. Okay, yeah, so make sure that you follow what I'm saying. See, what would be your initial management in this patient? So initial management, okay? Because questions they like, so like for fifth year and fourth years like that, those that are doing clinicals, they are expecting that me, I'm not going to be asked here when it comes to management. You are going to be, so there are some cases that need to what management, but the management that you're going to talk about is just what, not in details, but compared to seventh years are going to talk about like the actual management, what they can really do when someone comes with what such a condition. So take note of that. Okay, don't feel lazy to start about the what management. Also need to know the management. Okay, so now what will be the initial management if someone comes in with that? Okay, they come with this abruptio placenta that we know now. What could be your initial management? So what could be the first thing that you can do? There's a rule that they say under what obs and gyn. Okay, there's a rule. If someone comes with what vaginal bleeding, consider it as what emergency. Admit what the patient. The patient, you need to admit the patient. Okay, so we're going to admit the patient here. So we admit the patient. That is the initial management. So the first thing that we need to do is what? Admit the patient. Okay. But in this case, we also need to admit the patient. And this is what an emergency, because this is a severe abruptio placenta, which need what? Immediate what? Attention. Okay. Because it can also lead to what? Maternal what? Death. Okay. Admit the patient. What do you do now? If you admit the patient, we know the thing that we do. You do what? A, B, C. That's the second thing that you can do. Okay. But here, what I'll explain is about what? C. The C, the circulation. So for A, we know that you check the airway if it is patent. Okay. If it's not patent, you do those maneuvers. Okay. Then for B, you do, so B is what? Breathing. Breathing basically, you need to give them what? High flow oxygen, which is about 10 to 15 liters per minute. You give them like that. Okay. If they are hypoxic like that, give them. Then C, that is for circulation. That's why you can do at least a lot of things. Okay, for C, circulation. That's why we can now start doing like stabilizing the patient. Okay, so here what can you do? The first thing that you do that they advise is what? Insert what? So you need to obtain what? Large bore cannula. Large bore cannula. Okay. So basically they say two. They say two large bore cannula. Okay. After you insert the two large bore cannula, what do you do now? What do you do? Then you need to what? To infuse now. Start infusing what? Crystalloid. So crystalloid like what? Ringer's lactate and what? Ringer's lactate and normal saline. If you do this, you need to put what? Normal saline. Okay. And what? Maybe if you want, you can use Ringer's what? Ringer's lactate. Okay. Let's just say R lactate. R lactate. Okay, that's what you do. Okay, what is the other thing? What is the other thing that you can do? Okay, then you can also check what? Vitals. Check vitals. So vitals, what vitals like what? Pulse rate, you can check pulse rate, BP, blood pressure, respiratory rate like that. Okay, oxygen saturation, you check all those things under what? Vitals. So after checking vitals, respiratory rate, those pulse rate, blood pressure, oxygen saturation, you do all those things. So what are you supposed to do next? Okay, the next thing that you need to do is you need to start like also monitoring. Okay, you need to monitor. Okay, before monitoring, we need to do something which is okay, investigations. So you need to do investigation. Why doing investigations? Because you need to do like The reason why we are doing that, because you need to assess for something, okay? Something like what? Maybe they are having liver failure, maybe they need blood, so that's why you need to do under investigation. You need to do something. You need to do what? You need to do blood grouping. So let's just say blood G grouping and what T matching or cross matching. Okay, you do that so that maybe if there's a problem, like if since this is hemorrhage, basically they need blood, so you need to do blood cross matching, also blood grouping, do all those things. Okay, what else apart from this? You also need to do what? You also need to do about the clotting factors like that. Okay, those like the D dimers, you do that. Okay, then what else you do also? Prothrombin time, partial thromboplastin time, all those things you do. Reason being because these people, they are at increased risk of what? DIC, disseminated intravascular what? Coagulopathy. They are at increased risk of doing that. So you need to do that so that you know, so that you treat accordingly. Okay. So apart from that, then that's when you can do what? Monitor. So you can monitor now. You monitor. What are you supposed to monitor here? Okay. You need to monitor a lot of things. Okay. You need to monitor the urine output. So basically, for you to do that, for monitoring urine output, basically you need to do what? You need to catheterize that patient. Okay. You need to catheterize that patient so that you can what? Monitor the urine output, and the goal is that urine output should be at least greater than what? 30 mils per watt per hour. That's the goal that you need. Okay. So that's the thing about monitoring. You monitor that. Okay. So that's the thing about everything when it comes to what? Initial management. Okay. And when it comes to monitoring, don't repeat. So examination like the G2 examination like that, don't do that. Okay. Unless, okay, since we know the what? We know the diagnosis is APH secondary to a severe abruptio placenta. We know the diagnosis. Okay. But if you are doing repetitive what? Examination, like vaginal examination, what are you going to do to the patient? You are going to introduce maybe somehow infection. Okay, you are going to introduce that. So at least you need to under monitoring, you need to at least reduce the number of the examination that you are going to do to that patient, because you are going to infect that patient. Okay, so those are things that you can do. Then let's go to this last question, which is what is your subsequent management in this patient? So this is carrying about what? 4 marks. Also, you need to understand this one. Make sure that you understand this one. Okay. So subsequent management, basically they're asking us on how best you can manage what? Abruptio placenta. So what are they saying? They're asking us to what? On how you can what? Treat abruptio placenta. Abruptio placenta. Let's just say AP. Okay. Now, if you talk about AP, abruptio placenta, so we need to talk about something here. Okay, a lot. Because treatment of abruptio placenta, basically it has to be what? You need to know the classes, because it is treated according to the what? Classification. So how many classes do you know? Basically the most common classes, there are 2. Okay, there's the clinical classification, which is according to severity. Okay, and the other one is what? According to what? Anatomy. There are also three anatomical classification. Okay, so let's start with the clinical classification. Okay, what is the clinical classification? So this is the one that you are going to what? To use. Okay, clinical classification is going to have what? It's going to have what? Grade 1 is going to have what? Grade 2 is going to have what? G3. Okay, it's going to have what? It's 3 grades there. Okay, then what about anatomical classification? Anatomical classification, I'm not going to write. Make sure that you watch that video. Okay, for IPH, basically abruptio placenta, there is a video for that. So if you look at anatomical classification, it's further classified into what? There's what we call reviewed type of what? Abruptio placenta. There's also another one which is concealed abruptio placenta, and the last one is what? Mixed. Mixed means what? There is what? There is what? Reviewed and concealed at the same time. That is a mixed type of abruptio placenta. Okay, but we are going to focus on this one. The reason why we are focusing on this one, because treatment or management is dependent on the what? Clinical classification. You need to know this. Now the clinical classification depends on what? How many things? There are 4 things that it depends on. It depends on what? It depends on what? Bleeding. Okay. It depends on the bleeding. Okay. What else? It depends also on the pain. Basically, uterine pain. Let's say U pain, uterine pain. Okay. Depends on those also on the fetal heart rate monitoring. Okay. It also depends on what? The first, the last one is what? Placental separation. Placental separation. 4 important what? Aspects. Okay. If we talk about grade 1, the bleeding is what? Minimal. It's not that severe. Okay. If you talk about the uterine pain under grade 1 is what? It's not severe, and it is what? Localized. If you talk about the fetal heart rate monitoring, what do you use? They use what we call CTG. Okay. They use CTG to monitor what? Fetal heart rate. So if you look at this one, basically the CTG is going to show what? A normal fetal heart rate. So there is nothing wrong with the fetus there. Okay. Then if you talk about the placental separation for type grade 1, it is less than what? 20%. You need to know that. Basically, under grade 1, this mild type. So grade 1 is also called what? Mild. Okay. Mild placental abrupture. Okay. Mild. So basically, the fetus is stable. In summary, the fetus is stable, and also what the maternal, the mother is what? Also stable under mild. For moderate, this is moderate. Moderate, if you talk about bleeding, the bleeding is what? Moderate. The pain now at least is also moderate. The pain is moderate, okay? And sometimes it can be localized, or maybe it can be diffuse like that, okay? If you talk about the fetal heart rate monitoring, on the CTG there, if you see, you're going to see what? The mild to moderate what? Deceleration, late deceleration. There are different types of deceleration that I talked about in the last video. But here, just know that there are what? Late deceleration. Late deceleration, those are what? Abdominal deceleration. Basically, it's indicating what? Tissue, fetal hypoxia, okay? It's indicating what? Fetal hypoxia or fetal distress, okay? There will be that. And there will be also tachycardia to the fetus as well here. Then the other part is that under placental separation, there will be what? The separation will be greater than what? Remember, it will be between what? 20 to 50%, okay? Other they say 25 to 50, but 20 to 50%, that will be the placental separation under grade 2, okay? Then grade 3, if you talk about grade 3, the bleeding now is severe. So because this is moderate placental abrupture, then this one is what? Severe abrupture placenta. Then on the bleeding, it will be severe. Okay. What about the pain? The pain will be severe, which sometimes characterized as what? Knife-like what? Pain, which we call stabbing pain. Okay. Here. Then if we talk about the fetal heart rate, what do you think the fetal heart rate? The what? Very, very severe what? Fetal deceleration. Okay. Sometimes there is also what we call bradycardia. Okay. Instead of tachycardia, which we saw on the grade 2, here there is what? A bradycardia of the fetus. And most of the time there will be what? Fetal demise. Where on the grade 3, that's why it's common. Fetal demise, okay? So talk about the placental separation, it is about what? It is now greater than 50%. So those are the classification according to that, okay? Now if you look at here, the reason why we said our question here is talking about severe abrupture placenta. What were the indicative signs we talked about? So there is severe abdominal pain, which here I said there is that severe pain under grade 3. Okay. Okay. One feature. What is the other one? Fetal heart rate is not picked by Doppler sound, Doppler ultrasound. So if it is not picked, basically is what? Fetal demise. Why is fetal demise on the what? Grade 3 placental abrupture. So that's why we said AP8 secondary to what? Severe AP8 secondary to what? Severe abrupture placenta in prime gravid at 34 weeks. That's why we say like that, okay? But if you talk about the treatment, okay, if you talk about the treatment, grade 2 and what? Grade 3, they're going to be treated as what? One thing, okay? In some doctors they treat it separately like that, but generally grade 2 and grade 3 are going to be treated what? As one thing, or as the same thing, okay? G1, which is grade 1, is going to be treated like in a different way. So G1 is not that severe, okay? So I'll talk about G1 from here. So make sure that you pay attention. So for mild or grade 1 abruptio placenta, how can you treat that one? So basically, it's going to depend on something, okay? So before I go to this one, again, treatment is going to depend on what? So treatment of this, treatment depends on what? So it's going to depend on something. So depend on what? Four things. The treatment of abruptio placenta depend on what? Gestational age. So let's just say GA, gestational age is going to depend on that. It is also going to depend on the what? Maternal and what? Fetal condition. So let's just say core condition like that. So this one and this one, that one. And what else? The one thing that we from talking about severity, okay? The one thing that we are talking about severity of what? AP, okay? These are the important factors on things that they use to what? Treat abruptio placenta, okay? Now, from this data, let's say now, let's say someone came, if this condition was under what grade 1, what can you do? Under grade 1 now, grade 1, depending on the gestation age, so grade 1, this one, grade 1, so let us answer it from here. So G1, what can you do? So G1, basically, we know that the fetus and the fetus and the what? The fetus and the what? The maternal, they are what? They are stable, okay? They are stable. The fetus and the maternal, they are stable under grade 1. That's what we said there. Okay, what else? The severity, we know that that is grade 1. Gestation age. So gestation age now, it will be 2 of 2. So there is, if the gestation age is what? Less than what? 37 weeks. Okay? 37 weeks in this case. Okay? So less than what? 37 weeks. What can you do? Less than 37 weeks, what do you do? You do what we call conservative what? Management. You do what? Conservative management. What is conservative management? Basically, is something they refer to as that expectant management. You are not intervening, just you are giving them what supportive care like that. Okay, you are just trying to prevent what the complication that they are having, maybe that they might have. Okay, now under conservative management, the very important concept that you need to do is that you need to give what you need to make sure that you encourage bed rest to the patient, as well as what you need to give what betamethasone. Betamethasone, why giving betamethasone? That corticosteroid, because you, let's say the it's going to influence what the maturity of the lungs, okay, of the fetus. Maybe the fetus, let's say it's around less than maybe there's 2 weeks there, so you need to give what betamethasone for lung maturity, okay. So that's under conservative or expectant management. That's what you can do here. So G1, just expectant what management. Don't do anything. The moment now, if it is less than 37, you do expectant, okay. What if it is greater than what? Greater than 37. What can you do? Then you plan for what? You plan for delivery. You plan for delivery, because you don't have to rush, because that is something that is not severe. You plan for delivery, either vaginal delivery or what? C-section type of what? Delivery, okay. Now, there are some things, indication that you are going to be using for C-section as well as for what? Vaginal delivery. If there is no contraindication to vaginal delivery, yeah, make sure that the first choice will be what? Vaginal delivery. If now there are some contraindication to the vaginal delivery, maybe there is something, maybe the patient is having cervical cancer like that, cervical erosion, all those indications, then it will go to what? The mode of delivery will be what? C-section. So it will depend on the what? State of the what? State of the or the condition of the patient, okay. So it will depend on that, or the mode of delivery, okay. Then apart from that, now let's go to our question now. The question now is talking about what? Here we're talking about the severe one, okay. The severe one is what? G3. So this one is G3, severe. So we're saying here is G3. So let's just say G3 and what? G2 or grade 2. They are going to be managed one and the same, okay. So how can you manage now this one? This one, the only thing that you can do is what? The only thing, you don't even need to do anything as in expectant management or no. The only thing that you can do is what? Immediate delivery. What am I saying? The only thing that you can do is, regardless of the gestation age, need to what? Deliver. So delivery is what? Is the management, definitive management, you deliver. Okay, because in this case, if you look at the maternal is at increasing, so their maternal status is what? Is not stable. They are in the hemodynamic and instability. Okay, so if they are that, the only thing that you can do, first of all, we did the initial management like that. At least the patient is stable, in hemodynamic stable. Then after that, you deliver. Okay, delivered again is to depend. So the mode of delivery, it will depend on the status again of the what, of the patient. Okay. Okay. So what are we saying under this one? We're going to say, okay, regardless of the gestation age, because this is severe, we're going to what, induce what, labor like that. So the first one is what? You can do what, vaginal delivery. Okay. The reason why we're doing vaginal delivery, because there are no contraindication to vaginal delivery. Okay. So like let's say the first one is what? There is what? The labor is what? Imminent. Labor is what? Imminent, is just okay, like that. There are no contraindication to labor. That's when you can do vaginal what, delivery. What else? Okay, no fetal distress. Okay, no fetal distress. What else can you see for you to do vaginal delivery? Okay, no fetal distress. Then what else? Okay, then what else? The mother. So maternal hemodynamically stable. Okay, hemodynamically stable. That's when you can induce what, labor. Oh, okay. That's when you can do vaginal delivery if the condition or the status of the patient meets this. Okay, there's like the cervix is what, it's just okay. Oh, the cervix as well. Cervix is what, either maybe nearly dilated or fully dilated like that. Okay, so also look at the dilatation of what, cervix dilatation. Okay, dilatation. So now C-section. So when can you do C-section? So I'll just write it here. C-section. When can you do C-section? C-section, if the labor is not what? If the labor is not what, imminent, there is fetal distress, there is maternal hemodynamic instability, there is what? The cervix is not what, fully dilated. As well as maybe a patient is having what? Also some certain condition to the what? Vagina, okay? Like maybe there is vaginal ulceration, there is like those fibroids there, okay? A lot of what causes that can make sure that, okay, let's just deliver via what? C-section. Okay. Then after you do this, okay, after you do all this, then what else are you supposed to do? Okay, you deliver. Okay, after delivering, you deliver. Then what are you going to do after delivering? You do this. The next thing that you do is this. Okay, so you offer what? Okay, you offer. So after you offer what? Counseling. So you offer what we call counseling. Why offering counseling? I can't spelling for this one. Counseling, whatever. Okay, you offer what? Counseling. So why offering counseling? Because here, if you look at here, okay, the fetus is what? Dead here, because the fetal heart rate was not picked by what? Doppler ultrasound. The fetus is dead. So after you deliver there, so basically, and the other important thing that I left out is if there is what? The fetus is dead here, okay? If the fetus is dead, the mode of delivery that they like, the mode of delivery of choice is what? Vaginal delivery. You induce the labor like that, okay? But if there are some contraindications that I talked about, here we just imagine that the fetus is what? Alive, okay? The fetus is alive. If the fetus is alive, then you can deliver by this or by that, okay? But if in this case the fetus is not what? Is not alive. This is the fetus is dead. So what can you do? What you can do is this. You can just what? Deliver via what? Vagina, that's the choice. If now there are some contraindication, do C-section, okay? Then after you do all that, since the fetus is dead, then you offer what? Some counseling, okay? Some psychological counseling, okay? Then afterwards, after counseling, and what do? You monitor. So monitor the patient after what? Delivery. After delivery. monitor the patient after what delivery. Why? Because they are at also increased risk of what postpartum hemorrhage. So if there's postpartum hemorrhage, you treat it as well, okay, as one of the complications. So basically you need to what monitor them after what delivery, basically for 24 to 48 hours, monitor them like that, okay. Yeah, so that's why we end from question 1. Then question 2 we'll talk about it in the next video, okay. Thanks for watching.